Okay, so we get started. I'm Raj Dave for C3 Live from Harrisburg, Pennsylvania. This is our inaugural new show, which replaces Coffee Cases and Controversies. Stand up for your patient and the art of medicine is our goal here. And I hope this is a new structure of this show where we are going to have discussion on two contemporary topics, followed by journal watch, followed by clinical challenges. And I hope you all like this new format. For the very first show, we have solid attendance here today, including we are streaming live on Facebook. So welcome everybody. Without further ado, let me introduce our first speaker today, Dr. Christian Ruff. I saw him just a few minutes ago.
Yes, I'm here. Thank you so much for inviting me, Raj.
Thank you. So Dr. Ruff is a long-term friend of C3 Meeting, is a director of general cardiology at Brigham and Women's Hospital and senior investigator for the TIMI group. He has added a lot of science to our understanding of many different areas, including the new area of factor 11 agents, which are now in clinical trials. It's a important topic, given that DOAC, which has pretty much replaced warfarin, continues to have some bleeding events, and it always is a challenge in finding the best agent which has the least bleeding events with the best outcome without subjecting patient for a potential procedure such as left atrial appendage occluder. So this is a very important topic in my opinion, and Christian is going to give us an overview of factor 11.
Great, thank you so much. I'll share my slides. Great, are you able to see presenter mode?
Yep, fantastic.
Great.
Yeah.
Thank you so much, and it's really an exciting time. And this morning, I'd like to talk about factor 11 inhibitors, which are the new class of anticoagulants, and particularly, do we need another anticoagulant? Obviously, the DOACs have been widely adopted and are much safer than vitamin K antagonists such as warfarin. And then I'm going to tell you a little bit about their potential benefit and where they've been as far as the clinical trials that have been done, and really looking forward to the phase 3 trials. So as Raj mentioned, I'm Director of General Cardiology at Brigham and Women's Hospital, a senior investigator at the TIMI study group, and associate professor of medicine at Harvard Medical School. And these are my disclosures as a clinical trialist. And so obviously anticoagulation to prevent cardioembolic stroke really remains a cornerstone of our treatment for atrial fibrillation. And we and others were involved in the pivotal phase 3 DOAC trials that led to their approval really now over a decade ago. And in meta-analyses of those trials, they were as effective as warfarin in reducing ischemic stroke, but markedly safer with respect to intracranial hemorrhage, reducing those rates by 50%. And it was this reduction in serious bleeding that really drove the 10% mortality benefit of DOACs over warfarin. The advantage of DOACs, however, for reducing less severe types of bleeding was not as evident. While they tend to reduce major bleeding and there's some heterogeneity between the agents, they basically all increase gastrointestinal bleeding significantly as a class by 25%. And we know that bleeding is still a problem. This is 1-year data from the combined AF patient-level meta-analysis of 5 DOAC trials. And we see here that some patients have major bleeding rates that exceed 5% every year. Remember, this is a lifelong therapy. And we know from clinical trials and multiple registries that bleeding, or even the perceived risk of bleeding, drives significant undertreatment of patients. That really has led to our continued search for an even safer anticoagulant. And we know here, this is really shocking data from the Medicare beneficiaries database over the prior decade, that if you had a new diagnosis of atrial fibrillation in the last 12 months, almost 2/3 of patients were undertreated, which is really just a staggering amount. And this is on the higher end of some of the data that have been published. But data suggests anywhere really from 40 to this almost 70% of patients are either not treated or receive an inappropriate lower dose. And so factor XI inhibitors have really emerged as the most promising agent to uncouple hemostasis on the left, which is the ability to form a hemostatic plug in an injured blood vessel, from thrombosis on the right, where thrombus blocks blood flow in a vessel leading to organ damage. Now, factor XI is really required to drive thrombosis, but it's really dispensed and plays only a minor role in hemostasis. And so what we hope is to have a hemostasis-sparing anticoagulant where you're able to still repair a blood vessel if it gets injured, and you're able, though, to prevent thrombus amplification and propagation, which leads to a clot. And I don't want to get into the coagulation cascade, but factor XI really only sits in this thrombin amplification propagation part of the coagulation cascade, and not in the common pathway, which is where the hemostatic and thrombotic pathways merge. And if you remember from medical school, whether it's a 10A inhibitor, a 2A inhibitor, or warfarin, they all inhibit a factor in the central pathway. So they are effective in reducing clots, but they interfere with the ability to heal an injured blood vessel and form a hemostatic plug. And so that's nice. I could show you a diagram and say, factor XI is unique. It sits in this special part of the coagulation cascade, may be necessary for thrombosis, but not bleeding. But what evidence do we have of this? And actually, there's a tremendous amount of evidence that we've had for many decades. We know from human genetics that there are patients around who have absolutely no circulating factor XI. They used to be called hemophilia C. What's interesting about these patients, they seem to have a reduced risk of thrombosis, but no risk of serious bleeding, even with surgery, despite the fact that having absolutely no circulating factor XI. And then we know from other genetic epidemiology studies that if you look at factor XI levels in the population, those with lower levels have lower risk of arterial and venous thrombosis, and those with higher levels have a higher risk. And this has been recapitulated in animal studies. Now, what about clinical trial data? So here, so genetic epidemiology data, here is what I was pointing to you from the historical cohort from the Clallet Health Services. And we know there's a higher preponderance of factor XI deficiency in the Ashkenazi Jewish population. And we see here from around 10,000 subjects that patients with low factor XI, less than 50%, have markedly lower risks of venous thromboembolism, as well as stroke and MI. And so suggesting that this is a very powerful predictor of stroke. And again, they don't seem to suffer serious bleeding complications. So a lot of genetic epidemiology supportive, mechanistically it makes sense. Well, how would one target factor XI? There's been a lot of interest in this over the last decade. Well, there are several strategies, and you're familiar with this in other fields. You could develop antisense oligonucleotides, which basically prevent the liver from synthesizing factor XI. There are some other aptamers that bind to factor XI and block activity. Probably the two that are really being used most broadly in cardiovascular disease are antibodies that bind to factor XI, prevent it from being activated to activated factor XI, and then small molecules, which are reversibly binding to the active site of activated factor XI and block activity. And so, what are the basically pharmacokinetic and pharmacodynamic profiles? Again, we see here, these are the ones that are basically in late stage clinical development. You have abelacimab, which you'll hear about in a minute, a monoclonal antibody. That is an inhibitor of factor XI. So basically it binds to factor XI and locks it in the zymogen state, prevents factor XI from ever being activated. Osocimab is another monoclonal antibody. Fesomericins and antisense. One of the things about the antisense is they block the synthesis of factor XI, but it takes weeks for that to become therapeutic. So slow on, slow off. And then the two small molecules, asundexian and milvexian, they're direct activated factor XI inhibitors. They're reversible, fast on, fast off. What are some of the big differences between the antibodies and the small molecules? Well, obviously the antibodies and the small molecules are both rapidly active, but there's a much longer duration of action with the antibodies. They tend to last a month or more, where these small molecules are given once or twice a day. Also, all the small molecules have some degree of renal clearance and interaction with CYP3A4 and potential drug-drug interaction. So in that sense, the small molecules are kind of similar to what we've been doing with the 10A inhibitors, except they're inhibiting factor 11, where the antibodies don't have any renal clearance and obviously are not interacting with any drugs, but they're hanging around a lot longer. And that could be an advantage or disadvantage depending on how safe they are, which we'll get to in a minute. So what have the clinical trials shown us to date? And again, I think it's important to kind of take a broad overview and not go into all the specifically trials, but they've basically been studied across a spectrum of cardiovascular disease. As all anticoagulants that have ever been developed, their efficacy is generally established in the prevention of venous thromboembolism after orthopedic surgery. And you see here the various trials, all the different agents have basically shown they're very effective at reducing venous thromboembolism compared to standard of care low molecular weight heparin with similar bleeding rates. But what's unique about this is, yeah, the DOACs had VTE data, same thing, but the DOACs were used in much lower doses for VT prophylaxis, not the stroke prevention doses. What's very interesting about the VT prophylaxis data is in the dose ranging studies, they used fully therapeutic factor 11 inhibitors. So the dose that you would use in stroke prevention, yet the bleeding was similar or less than enoxaparin given prophylactically. That was the first suggestion that these agents may really be a game changer with respect to safety. They were studied in atrial fibrillation in 2 trials. The Pacific AF was a small trial with asundexian and only had 12 weeks of follow-up. So small number of events. There were no major bleeds in that trial, but it suggested, at least for clinically relevant non-major bleeds, in a pooled analysis of the milvexian dose of the asundexian doses, that it was safer than apixaban. And then I'm going to present to you in a moment more detailed data about the Azalea-TIMI 71 trial, which we just presented as a late breaker trial at the American Heart Association. They were also used in secondary stroke. And remember, this has always been a challenging field for anticoagulants because we know that anticoagulants are effective in non-cardiomyopathic stroke, but that is usually necessary to be on top of at least dual platelet inhibition for at least a couple of weeks, followed by single antiplatelet. And then combination antithrombotic therapy led to high rates of intracranial hemorrhage. So in these studies, they were basically adding full dose, essentially factor 11 inhibitors on top of DAPT and then transition to SAP. And what's amazing is that there was really no increase in bleeding, including intracranial hemorrhage, with some suggestion that it may reduce stroke, is particularly large vessel atherosclerotic stroke. And then there was a single trial, Pacific MI, too small to really see any efficacy, but did demonstrate the same principle, that another field where we know that anticoagulation reduces cardiovascular events after AMI, but using the bleeding is intolerable with triple therapy. And this was essentially adding factor 11 inhibitors on top of antiplatelet therapy after an MI, and there was no increase of bleeding. So it kind of really sets the stage, suggesting that the factor 11 inhibitors will have low rates of bleeding, and that because the rates of bleeding are so low, we may be able to use it not only in atrial fibrillation, where there's a class 1 indication, but in other areas where we know anticoagulation works, but the bleeding has been prohibitive with combination antiplatelet therapy, and that's secondary stroke and MI. So I'm going to present just briefly the Azalea-TIMI 71 trial, which I mentioned we presented at the American Heart Association, because this really cements the safety and the promise of factor 11 inhibitor. This is the largest and the longest of any factor 11 inhibitor that has been done to date. Randomized 1,287 patients to either abelacimab 150 milligrams sub-Q monthly, abelacimab 90 milligrams sub-Q monthly, or standard of care rivaroxaban 20 milligrams with appropriate dose adjustment. Event-driven trial targeting 166 major or clinically relevant non-major bleeds. We were actually alerted in September this year that the Data Safety Monitoring Board recommended termination of the trial due to an overwhelming and substantial benefit of abelacimab compared to rivaroxaban in both doses, with the benefit risk that favored abelacimab. So we knew going into the AHA that there would be a big result for the DMC to stop it, but I think we were surprised with just the magnitude of the reduction. Here you see both doses of abelacimab resulted in substantial and highly significant reductions in major or clinically relevant non-major bleeding, a 67% reduction in the 150 milligram dose, and a 77% reduction in the 90 milligram dose. And what I didn't show you, but this bleeding that was remarkably safer was with almost complete inhibition of factor 11, greater than 95% over with both doses. In fact, the higher dose blocked factor 11 activity by 99% and the lower dose by 97%. So sort of with the antibody, you're recapitulating congenital factor 11 deficiency. And I'm just showing you data now for the 150 milligram dose, which is the dose being studied in phase 3 trials. And not only did it reduce the composite of major or clinically relevant non-major bleeding, but if you looked at major bleeding alone, which is essentially bleeding that leads to hospitalization, reduced by 74%. And I think the thing that we were most excited about is it essentially eliminated gastrointestinal bleeding, which we know is about 2/3 or 3/4 of the bleeds that we see in clinical practice with DOACs, a 93% reduction in both doses. So really potentially a game changer with respect to the safety of anticoagulation. So where do we go from here? Well, there are a lot of phase 3 trials that are ongoing. Unlike the DOACs, which kind of staggered the indications really over a decade, sort of everybody's doing their phase 3 trials simultaneously. And here you have the 3 compounds that are kind of in most advanced stages. I just showed you data from abelacimab. We're also running the LILAC-TIMI-76 trial, which is basically the abelacimab 150 milligrams in very high risk atrial fibrillation patients that have been deemed ineligible for anticoagulation. So the elderly with multiple risk factors, fall risk, their physician says, I can't even prescribe our safest DOACs. And that trial is enrolling. And then there are 2 other trials with the monoclonal antibody, Aster and Magnolia, which are cancer-associated VTE, which is a very high-risk patient population for bleeding and thrombosis, going against apixaban in a general cancer-associated VTE and dalteparin for GI malignancies. Remember, the DOACs are not great for GI cancers because the DOACs cause a lot of GI bleeding. And so they're generally not used with GI malignancy. Now, there are 2 active comparator trials in atrial fibrillation happening as well, and that's Oceanic AF, which is the small molecule asundexian, and Librexia AF with milvexian. These are 15 to 20,000 patient trials going against apixaban in a general AF population with a primary endpoint of ischemic stroke or systemic embolism. These are non-inferiority trials, but we'll get a better sense of really truly defining the efficacy of the DOACs compared to the factor 11 inhibitors. They look to be effective in the phase 2 studies. The rates of stroke were very low, say in the atrial fibrillation trial, but obviously to be able to fully differentiate exactly how effective they are compared to a DOAC, we need the large trials. And those trials are also ongoing. Many of you may be participating in them. There are also 2 secondary stroke studies with asundexian and milvexian, Oceanic AF with asundexian and Librexia stroke with secondary with milvexian. There is only a single ACS trial that's being done with milvexian called Librexia ACS. And so I think that will give us further information regarding whether there's a benefit of adding a factor 11 inhibitor on top of antiplatelet therapy after an ACS. And so really we could have in the next few years indications for factor 11 inhibitors for stroke prevention, atrial fibrillation, secondary stroke prevention and non-cardiomyopathic stroke after ACS and in cancer-associated VTE. So at least 4 indications for factor 11 inhibitor trials, all in ongoing clinical trials that are currently happening. So an incredibly exciting field, and I think people are really energized by the fact that the bleeding is just remarkably low with these compounds, and they're truly hemostasis-sparing anticoagulants. And so, what does the future of factor 11 look like? Well, it's important, I think, based on Azalea and some of the other studies. One thing we could be certain is that factor 11 is substantially less bleeding than DOACs. That was, we had a sense of that from the genetic epidemiology, animal studies, but I think we've locked that down with the clinical trials to date. And they're safe across a broad range of bleeding severity and locations. And we know that bleeding is really the driver of selection of an anticoagulant, as well as whether patients stay on it. The one thing we don't know is whether the different strategies matter with respect to factor 11 inhibition. As I told you, there are antibodies, there are antisense oligonucleotides, there are small molecules inhibitors. They work in different ways, and so we don't know if that's going to matter. In some ways, you'd expect an antibody or an antisense oligonucleotide to be more effective because you're preventing factor 11 from ever being activated, where small molecules work by factor 11 gets activated, and then the small molecules got to bind it before the factor 11 inhibitors do their business and cause a clot. But we really don't know if that's true. Obviously, the small molecules last for a much shorter amount of time. They're out of the body in 12 to 24 hours, like the 10A inhibitors. That obviously would be a big deal if the factor 11 inhibitors weren't safe, because then you'd be concerned about procedures. But if they're really as safe as they seem to be, then maybe having a long-acting drug is better for compliance. And I will just note a plug that we're hoping to present peri-procedural data from the Azalea study, which has a half-life of 30 days for the drug. And about 80% of the patients who had a procedure on abelacimab, and they had all sorts of procedures, it was done fully therapeutic on abelacimab. And we know that the bleeding rates are low. So that'll be I think important to give physicians comfort in using these drugs during procedures. And then, as I mentioned, somewhere within the next 3 to 4 years, we may get approval across a broad spectrum of cardiovascular disease. As I mentioned, atrial fibrillation, secondary stroke, ACS, and cancer-associated VTE. So really an exciting time. I do believe, kind of like the DOACs led to a revolution in anticoagulation compared to warfarin, I think the promise in the future look bright for factor 11 inhibition, and I think there'll be a lot of exciting data to share in the coming years. So thank you so much for your attention, and Raj, for the invitation to present at this inaugural format. I very much enjoyed C3 in the past, and happy to take any questions.
Thank you very much, Chris. That was fantastic. So Dr. Ballard is a vascular surgeon, and our practice is very much vascular these days, and we use a fair amount of DOACs empirically in vascular medicine. And we're also now treating a lot of patients with deep vein thrombosis. We're also treating a lot of patients with arterial clot, especially since COVID. And a lot of these patients end up on DOAC therapy. And one of the biggest limitations for us is, even patients, those who have femoral popliteal, plastic grafts, that long-term anticoagulation is a problem because of the bleeding. So I think this therapy, I'm sure it will get tested in PAD.
And I will say we are adjudicating, it's not dedicated PAD trials yet, although they're in the life cycle of many of these development, but I think we've learned from the past, we are adjudicating PAD events in the phase 3 trial. So then not specifically enriched, but we will have at least adjudicated PAD events that I think shed some light, that at least show that there are consistent reductions in PAD events and amputation, et cetera, revascularization. But obviously the dedicated PAD trials and vascular studies are planned. They'll be a little bit staggered from these initial indications.
Sure. The question that I have for you, Chris, in long term, and this is obviously, after these agents start getting approval, is that there might be a nice to do a comparison study in patients who are at high risk of anticoagulation versus left atrial appendage occluders, because it has it has definitely become more common now
Right.
to have patients getting left atrial appendage occluders these days, and certainly the potential risk of that procedure still exists. We have had a couple patients with complications
Right.
related to, and it may be that this strategy may be worth it.
Absolutely. I think, the main advantage of left atrial appendage occlusion is obviously the initial procedural risk aside, the long-term safety, because patients don't need to be on an anticoagulant. But I do think that this changes the calculus, because if the bleeding is essentially what you would get with prophylactic anticoagulation, much lower than the DOACs, much lower than aspirin, et cetera, would this be a really attractive strategy in comparison to left atrial appendage occlusion?
Absolutely.
And obviously that, I think that will be, those are studies that people are talking about, because that needs to be done. These are two legitimate options in very high risk patients that we don't think can tolerate, standard of care DOAC, or maybe don't want to. And so those are very important studies to be done, so we could really figure out like which patients should be on a factor 11 inhibitor and which patients, should be referred for occlusion. I think because I saw. Oh, I'm sorry. Go ahead.
No, I think that the calculus will change even faster than that. I think we all know that in left atrial appendage occlusion, the thrombus from the left atrium, the left atrial appendage, is absolutely prevented. But we also all know that 10% of the thrombi come from the left atrial in the form of a mural embolus, and the left atrial appendage occluder does nothing for that. So the algorithm which gets you to left atrial appendage occluder will never get there if there's a successful factor 11 drug in the way.
And I think the other important point you raised, like not only say clot from atrial fibrillation in the atrium, not just in the appendage, but these patients are also having non-cardioembolic stroke to large vessel athero. They're having MIs and other things, and you obviously are getting broader vascular protection because you're on systemic therapy. And so really, like you said, the appendage, occluding appendage, really accomplishes just, substantial reduction in cardioembolic stroke, but not even all cardioembolic stroke. As you said, there's some residual stroke from clots in the left atrium. So I think this would be, if the bleeding is as advertised, which I think we're sure it would be a game changer.
I think there's another area that is really quite rich, and that's in patients with treatment for DVT, particularly people with post-traumatic syndrome who end up with stents. At our last live C3 meeting, we had a rousing discussion about what to do after an iliocaval stent is placed, and there was complete absence of unanimity about what to do with those patients. From lifelong heparin to a scaled down dose, and a drug that's an anticoagulant with no bleeding issues is a game changer there. That's a home run.
Yeah, and actually it's a great point, because I forgot to mention one part about, if you look at the coagulation cascade and you look at factor 11, it's in the intrinsic pathway, which is where contact activation is.
Right.
And so where you think these drugs are going to be remarkably better than, say, DOACs or other drugs, is things like stents. Obviously, you could use these drugs in mechanical valves, LVADs. So in these areas where you have a foreign body and you get contact activation that's leading to some of the thrombosis, that's essentially in that pathway. And so while they're broadly great for VTE and stroke prevention, atrial fibrillation, they will really shine in areas of stents, in mechanical valves. They're being developed in LVADs, even in patients with end-stage renal disease for dialysis, catheters, et cetera. So they may have a particularly rich advantage in the setting that you described, where not only do they have a significant amount of athero or embolism where this works, but because there are issues with obviously an increased risk due to the stented regions. And so I think this is really an ideal class of anticoagulant for that type of patient.
Gigantic. I have one more question for you, and that's our experience with DOACs was, in spite of the fact that as you looked at them, they were a home run compared to warfarin. There was a slow uptake, and the slowest part of the uptake was not so much any of the bleeding effects, but the fear of bleeding effects.
Right.
And the fear of bleeding effects were ameliorated to a great degree when decoy molecules for rescue came around. And I would predict the same thing here, particularly if it's an injectable 30-day. I think that physicians will be absolutely afraid to inject something where a patient might have a bleed in 30 days without something to rescue. So maybe not even so much for bleeding, but for the psychology of bleeding, having some sort of a reversal strategy available would be an interesting.
Yeah, it's a great question. I know all the companies are sort of thinking about that. Obviously, they're so much safer that the need for reversal will be even less. But I think you're right, particularly for the monoclonal antibodies, they're pretty easy to reverse because you basically can bind that irreversibly. I will say, based on the patients with congenital factor 11 deficiency, one general drug that is actually pretty effective for factor 11 deficiency is actually TXA. And so one sort of non-specific reversal that we actually recommended in the trials, which people use broadly in CABG and other types of scenarios, that may also, as we await for the reversal agents, specific reversal agents, that tends to be a very effective strategy. And like you said, I think we're going to show some data, hopefully at the ACC, regarding management of periprocedural bleeds on a long-acting factor 11 inhibitor, which I think will at least generate a lot of questions and hopefully alleviate some of the concerns about what you would do if someone was fully therapeutic on a factor 11 inhibitor.
Is it possible to measure factor 11 activity levels before and after TXA?
It is. Yeah, we don't have that data from the trial, but the companies are now, basically in more limited studies doing that. It was hard to arrange kind of in the setting of someone getting a procedure to do in a clinical trial, but you can sort of test that in a more controlled setting. And so those studies are being done as well, which I think will be kind of important just mechanistically.
Interesting. Great talk.
A question from Dr. Gustavo Samaja from Argentina, that what may be the cost of these drugs?
Yeah, so this is a great question because as you could tell from the timeline, when I'm saying a couple of years, varies from country to country as far as availability. But the DOACs will be generic really by 2028, particularly apixaban because it's the most common one. And so people have said, well, we do know if these drugs are as effective and far safer, everyone would prefer to be on that drug, right? Because bleeding's like 70% lower. But obviously, it's a $40 billion market. It's challenging to switch everybody. So what I think there's been discussion about as these drugs get approved, like let's all agree that there are some patients who absolutely should be on a factor 11 inhibitor. They're not currently a candidate for a DOAC. They've bled. They're particularly high risk of bleeding. Let's make it easier for those patients to get access. And then I do think there's going to be a legitimate, depends on the country. I know in the United States, this will be an issue, a legitimate saying like, well, if there's a patient been on a DOAC at relatively low bleeding risk, hasn't bled, should we really have them switch when the difference in price is going to be substantial? So one of the things in any new drug, whether it's PCSK9 or the DOACs, when there's an initial saying like, well, let's give it to everybody, there's a lot of suppression by payers or government healthcare systems to try to limit access so you don't get everybody flooding to the new therapy. And I think there's been recognition is that, well, we need another strategy for these. We have to all agree in advance that cost is an issue, but there are a bunch of patients, I don't know if that's 30, 40%, that really this is going to be the preferred strategy. And then I think have a reasonable discussion about there may be some other patients where there's more equipoise, they're doing well, and because of cost constraints, depending on the specific healthcare ecosystem, that DOACs will still obviously have a role going forward.
That's great, Chris. Thank you so much. That was outstanding. What a great start to the new show. I really appreciate it. And thanks for your time on a Saturday.
Thank you so much. A pleasure to speak to you all today. Thank you for the invitation.
Thanks. Great talk.
Thank you.
Great. So I don't know whether Dr. Kirti Punamia India has joined us yet. But if not, we'll continue. And I'll now invite Dr. Goran Olivekrona, one of our course co-directors of C3, to lead us into a clinical discussion of a case. So the way we have planned the case presentations today is that at a certain point, so in the case, we're going to stop and invite other moderators to lead the discussion about what they might do with the procedure, and that's how we're going to do it, to try to keep it the most engaging and interesting. So Goran, if you're ready, we can see your slides now.
Okay.
Hi.
Hi, Josh. How are you? Good to see you.
I'm well. How are you?
Good. So I'm trying to bring this online. It's interesting CTO case that I did a while ago. I'm just going to bring it up full screen so that we can. Everybody see full screen now?
Yep, we see just perfect. Yeah.
Okay, so this is a complex case with multiple issues, and feel free to stop me. I can stop at some points, but if you feel that you want to go ahead and stop me because it's a good talking point, then please let me know.
Sure.
So basically, this is a CTO case of a right coronary artery, and these are my disclosures. So it's a 63-year-old guy. He has had CABG in 1994. And his right coronary artery was occluded at that time. He then received a number of grafts and had multiple PCI of the right coronary vein graft, and it was occluded in 2012 finally, and left unoccluded. And he's gone through all the testing and has ischemia in the right coronary artery territory, which has an occluded native and the vein graft. And he used to be quite heavy, and he has lost a lot of weight, and therefore he has gotten a lot of his function back, and now he has pretty serious angina. So this is what the right coronary artery looks like, and it's been included since 1994. You can see the stents from the vein graft, but that's been included since 2012. And here's the lima to the LAD. You can see the right coronary artery filling up, mainly through the PDA, but also a little bit through the posterolateral. But it's an ambiguous distal cap. We don't know where this vein graft is situated, how far out it's stented, if it's in the PDA that it goes through, or if it's the distal right. And these are one more image of the collateral. So it's a pretty substantial right coronary artery territory. And you can see here also the posterolateral branch coming here. The marginal branch has some collateral that goes down to the posterolateral branch. So it may be that they're connected and doing okay. So you can see the PO branch here. The planning was basically it's a heavily calcified lesion. There's an ambiguous distal cap. Most likely there's a stent across. That the vein graft goes to the right coronary artery, long length. We need 3 catheters, but one to the lima, one to the right coronary, and one to the left coronary to fully visualize the right coronary system. And plan A was antegrade, possibly with crossbus. Plan B through the native marginal, through the PL. And plan C, open CTO-LAD for accessing the collaterals and going the native way. So this is then what our setup started with. So we have lots of catheters in here to really visualize this full right coronary artery system. And we can see here now that there is some connection and distal right coronary artery, still unclear where the stents are located. So we continue then with antegrade and continue for a while, and then we sort of get stuck. You can see that's really calcified where we're trying to get our microcatheter through. And we continue with this, and then decision finally to go retrograde because we get stuck antegrade. We're not getting any further. So we then go in through the posterolateral branch with a microcatheter and cross over into the distal right. And then the problem becomes where, we get the corset quite nicely over on the right coronary artery, but where do we go up into the right coronary artery? Where does the stent end? It's an ambiguous distal cap, and and this is the problem then of we're trying multiple wires and trying to elucidate where should we go. We can be judging a little bit from the calcium, but this is a problem for us. And we try lots of different wires. Finally, we can sort of feel our way up here with a CP12 wire, which is a very stiff wire, and through the distal part of the stent. Then with the help of a halberd, which is essentially like a Gaia 12, we can continue up a little bit, and after we get to this part, we can bring in a pilot wire and try to knuckle our way up. And this is where you can see that the wire is in a different part compared to the stent from the vein graft. So we're pretty confident that we are now in the real right coronary artery distally, but through the stent. And then we could actually continue, get the microcatheter up through the stent into the distal right, and then continue up and essentially cross over up into the right coronary artery using a knuckle wire strategy.
So Goran, if I may stop you here.
Yes.
So, when I look at this anatomy and look at the contemporary practice in US for interventional cardiologists, I would say that, and I think we have some other interventionalists on moderator panel, but I would say that 80% of the operators will say, we're not going to be able to do this interventionally. And indication, may not be that strong. So, what's your feeling about, the indication of treatment?
I think there has to be a very clear indication of doing a complex case like this. And you have to take into consideration, in my hospital, they mandate that we have to have non-invasive ischemic testing on all the patients that we do CTOs on. And it has to have patient has to have substantial symptoms, and it has to be substantial territory supplied by this occluded artery. So, then there are a number of patients that have really large occluded territories, but maybe not have so much symptoms where we feel there's no indication. And on the other hand, there might be patients with smaller territories that have a lot of symptoms. But essentially, it also adds to my attitude to actually really trying and be successful in treating these complex patients, because I know we have a strong indication. We have been accepted for PCI at a multidisciplinary conference where we bring up these patients specifically.
Okay. The other question I had was that, now you have so many different catheters in there and so many different wires. What's the anticoagulation strategy? What ACT do you run for this type of case? Do you give extra heparin, or it's 70 units per kilogram or 100 units per kilogram heparin? And how frequently do you manage the ACT?
I start out with giving more than 100 per kilo,
Okay.
and a little bit more. It depends on. And then I aim to have ACT well above 250, somewhere close to 300 when I do the retrograde. Some people would argue about putting it up to 350. I feel that any time you're above 250, you're okay. And it's very rare that we see thrombotic issues with these patients. Depends on the length of the procedure, how long time you have catheters, the dwell time. If we're not using the Lima catheter for a long time, then it's a good idea to bleed out before you inject them.
So I just want to orient some of the attendees which are with us. who may not have that much CTO experiences. So you have I see a AL1 or a AR1 guide in the RCA, and then there is a support wire up in a AV branch or something.
Exactly.
And then there is a wire anti-grade, which appears to be in a non-main trunk of the RCA. It appears to be an RV branch or something. And then there's a retrograde wire, correct?
So the retrograde wire with a microcatheter, and that's where you see the wire sort of at this chunk of calcium in the proximal right coronary artery, and that's coming down from the retrograde. And exactly like you said, the antegrade wire, and that's where we gave it out, was that we were very uncertain if it's even in the right coronary artery anymore.
I see.
So, and when we see the AL1 catheter that's placed in the proximal right.
Gotcha. And the retrograde access into the PL branch is obtained from LAD or circumflex?
Right. Because the patient has included LAD, and if there was a lima to LAD, and that was one of our options if it wouldn't work. So to get the retrograde wire from circ to the right, then we could have gone and opened the proximal LAD CTO, but just to get access to the septals.
Gotcha.
But we're through an epicardial artery here.
Gotcha. So, okay, I'll let you go forward with the case now, so you can explain now what is going to happen now.
Yeah, so
Because this is actually a pretty important point. Right now, you are at a point where either you are going to recross or the case will fail.
Exactly. So I'm trying to get my way up here. I mean, I'm in a position, if I can get the wire a little bit further up, then I can bring in an antegrade balloon. But I need to get that the retrograde wire further up, where I feel confident that the wires are dancing together, and I have a little bit of a territory where both wires are in the same architecture, or at least below the adventitia. So this is the point where I'm doing that, and this is then the next step. When I've gone a little bit farther, you can see the wires are dancing with each other for a little bit. The wire coming down from the retro or the antegrade catheter on the right, it really looks like it's outside in the distal part. But I'm now bringing an antegrade balloon in and trying to do what is called a reverse cart. In other words, dilating and bringing that wire up. And the wire is trapped in the guide, the Corsair. You can see here what happens. You can get access here now. The wire crosses into the antegrade guide in the right coronary catheter. So the next step is, it's pretty straightforward, you would think at this point, and I bring up my microcatheter retrograde into the guide, and then we can externalize the wire. So comes in one groin, goes out the other groin, and you think you're pretty much home free at this point.
Yeah.
And the problem is then that after externalized the wire and I'm trying to back out the catheter, it's stuck. I can't bring it out. And
now this is a retrograde catheter that's stuck, or the antegrade catheter that's stuck?
Retrograde catheter that I brought all the way into the guide.
Right. Because it's jammed into this proximal calcium.
It is really jammed, and I think one way to illustrate this is I'm trying to pull this back, and it's I'm lifting up the whole heart when I'm pulling here. So there's no way to get it out. It's stuck. So the problem is, what do you do then? Well, the way I look at it, this is something used for sailing, and this is where you tighten your sails. You bring a rope through it, and it swivels out, and then when you bring it, that locks it in place. And essentially, this type of lock is if you know about sailing, what I think the microcatheter has gone through. You can bring it one way, but you can't bring it the other way.
So, this is what I was going to suggest, that, okay, let's balloon that calcium, and see if we can disrupt, that calcified plane to see if the Corsair can get freed up.
Yeah. I mean, this is what I sort of wanted to try to do, the first thing is just bring an antigrade balloon down, and no, not successful. Then we sort of antigrade rewiring around the calcium. If you can't go through it, go around it, and we try shockwave antigrade. It does not work. We try non-compliant high-pressure balloons, not successful.
Wow.
We try to do atherectomy with 5 French, 6 French peripheral guides that we can fit into this guide. So like a child and mother does not work either. So try to do an atherectomy. We try cutting balloons, not successful.
I also now see that there is some dissection, from the guide at the origin of the RCA, which extends into the aorta.
Exactly. So this is one of the things you have to be careful of also. I felt a little bit, didn't want to go to a rotablader or something like that. It's a little bit issue where is the distal wire from that I put in antigradely now. I don't know if anybody has any suggestions on what to do.
I would say that this is a very frustrating, to say the least. I'm sure that the operator, those who are in the room, that's very frustrating, because you have now not only a problem, that the RCA is occluded, but now the retrograde channel also has a catheter in it, so that's obviously coming from an open vessel, and now that vessel is in jeopardy too.
And then we're also, be mindful, we've gone through epicardial collaterals. So, I mean, there's a limit to how much, you can do here and how aggressive you can be so you don't get a rupture.
Yeah. So the only other thing I can think of is, and this is, I'm sure this is fairly far-fetched now, but, we can try to snare the tip of the microcatheter from the antigrade guide and move the catheter around a little bit and see if it frees itself up to be pulled back. But that runs the potential for damage to the tip of that retrograde corset access, and once that tip is damaged, then you're not going to be able to wire through that. So that's a challenge.
Yeah.
Another question is, if you have a wire across, so you have a straight wire that goes through your catheter, can you put another catheter and try to push it with the tip and move it as a single system while you're pushing with one and pulling on the other side?
Well, and we actually did that very carefully. One of the issues is here that you can get sort of stuck tip to tip, if I understand your question correctly. So, we did that with that a little bit careful, because you don't want to end up, having something stuck tip to tip either. But so we sort of, what you've seen now is what we did for the better part of an hour and a half, 2 hours. And we did, more and more shock waves, and then and non-compliant balloons, and finally, after about 90 minutes, it dislodged. We were quite happy, but we have still.
So one question that Goran is that, were you counterclocking the corset access or clocking or just pulling on it?
Everything, both.
Yeah.
I mean, essentially, if you try to unscrew it, you should go clockwise. As you're putting it forward, you want to go counterclockwise. For the main part that I will usually do, it's like 70%, 30%, or something like that.
Mm-hmm.
I don't want to lose the tip of the catheter either. But at this point, we finally got it loose. And then the question becomes, what do you do now? And we still need to get a channel there. We kind of don't want to give up your wire. The couple options here could have been to take out the externalized wire, exchange it to another wire, But we kind of wanted to sort of get rid of dealing with the calcified nodule and break that apart. So we actually took a Tornus 2.6 across. That got stuck antegradally, but fairly quickly it came loose. And then, let me see, so that the computer doesn't freeze up. Then we could go over some balloons here, but we still had a dog bone on the balloon.
Sure.
So we're going to have to solve that dog bone somehow. The question is, should we give up the externalized wire and go around it? A couple of options here. Didn't feel, one way would go antegrade down and with using this externalized wire and try to get a rotor wire in there. That would be one option. But what we did was that we could not dilate this and couldn't get shockwave to go through. The only thing we could get through were small balloons, and they ruptured. So we took a dual lumen Sasuke catheter from the retrograde to, it was a pretty nice sized epicardial collateral from the circumflex to the posterolateral branch, and went that out. And this is the Sasuke catheter. The interesting thing is that this is a ring of calcium that's now become loose.
I see that. It's moving down into the vessel.
Yeah, the calcium is
that is a one heck of a movie. I don't think I've ever seen this endarterectomy in the right coronary like that.
I haven't seen that either, and I hope I will never see it again. This dual lumen catheter was, in other words, to get a second wire. This is on the externalized wire, but to get a second wire externalized around the calcium. So we're on the outside, because I don't think we can deal with this from the inside. So we need to be around it. And therefore we could then go up with a second wire. This is this even better picture of the calcium moving, I think. It's just a chunk of calcium. So second wire up to enters guide, we trap it, we externalize it, and then we sort of have to be very careful how you take out the wires with taking the corsair on the second wire, then back on the first wire, and then finally we can safely take out the first externalized wire. But for a while we had two externalized wires in the patient. And after that, we can now treat the calcium from the outside, and ended up stenting, putting the stents in there. And then it became a pretty easy procedure once this was solved. And here we were careful about injecting not too hard, because of what you said in the beginning of the proximal right coronary artery. We're a little bit hesitant about that. And this is then from the guideline that we inject. But the coronary artery is open. And this is what it then, 8-hour procedure. And he came back for follow-up angiography. And this is what it looked like when he came back. And he was completely asymptomatic at that time. So there's some focal stenosis in the distal right that we later on did PCI on. But it's open, and the best way to handle complications, avoid them, but always be observant and expect the unexpected. And if complications do occur, do your utmost to manage the complication as best as you can. We also use two operators, and an 8-hour procedure is very useful to have a colleague with you to help you and for support and ideas. And know your equipment. There's a lot of equipment that we will use here, but you have to have knowledge of this whole toolbox that will help you stay out of trouble. So, thank you, Raj.
That was great. Thank you very much for showing a really, really difficult case. I am glad that I was not the one who was doing the procedure. Yeah, that is a one heck of a complication.
You asked for a case, Raj. So complex case.
Yeah, no, absolutely. Absolutely. Thank you very much. Any other, Brian, Nilesh, any other comments? Otherwise, I will show the next case.
It was an excellent case. I don't
Yeah,
know
good case.
how you maintained the patients for almost 8 hours doing this thing. I'd have run out of that. Excellent case.
Thank you so much. I'm just glad that not all cases are like this.
Okay, let's show something a little bit more straightforward. Okay, can you see the screen now?
Yes.
Okay, so this is a 82-year-old oral surgeon, retired. He was admitted at a nearby hospital. He has history of diabetes, hypertension, and hyperlipidemia. And he was found to have an ostial and a proximal RCA, which was calcified, 99% stenosis. And the left system did not really have anything that critical. Here's the angiogram. You can see there is a heavily calcified diffuse disease, proximal right. This patient was then referred, to my center, and this is what I did, so we had really difficult time getting a microcatheter or the wire through, through this lesion. So I had to primarily wire this lesion with a rotofloppy wire, and then we did a 1.25 rotoblader burr, and then I was able to get the IVUS catheter into this lesion. So in a moment, we'll play the video of Dr. Vetrovac's journal watch. And there is a comparison study that is between OCT and IVUS, and we're going to talk about this study in a second. But you can see here that you can't tell the thickness of the calcium in this vessel. You can see that there is a very bright calcified lesion. However, I was able to expand this, and there were 2 Zion stents replaced, in this RCA, and he was then discharged. He went home on a dual antiplatelet therapy. He gets readmitted in 2 weeks to an outside facility. He gets ruled out for MI by enzymes, and they do another nuclear stress test on this patient, which shows large inferior ischemia, and he was referred back to our center, and that's the angio. So we'll stop at this point. I'd like to pull the moderators in to the discussion about what do you think is going on with this stent, which has just been placed 15 days ago, with image guidance, rotational atherectomy, and excellent, deployment.
Right. I think it's a couple of things that comes to mind. I mean, one thing would be thrombus, which
Yeah.
it look like. I'd have to see it with IVUS or OCT to see if there's anything that looks like a fracture in here, or if there's compression. Those would be sort of my, maybe some, like somebody in the text chat just said now, something prolapsing from between the stent struts and in from the vessel wall.
The reason why I didn't thought that there is anything could be prolapsing, because on the final angiogram just 10 days ago, there was nothing prolapsing in there. Everything looked perfect. This is just 2 weeks,
Yeah.
after intervention.
So you'd have to do imaging on this too as your next step.
Absolutely. I mean, if it was a soft plaque, there certainly could be prolapse through the stent struts, even if it didn't show up initially. But
Okay.
the fact of the matter is, that's an unlikely event. So, I mean, I think imaging is really not only for identification purposes, but for also how you're going to treat it.
Yeah, crucial.
Okay, let's show you the imaging now. So this is an OCT run now through this situation. And here's the OCT. I'm gonna play the OCT run. Hopefully it won't play. It won't play, but you can see, on the OCT run here, that see this hole here? This is your proximal struts here. This is where the guide is, just for orientation. There is some, under expansion here on these designs, and then or this is I'm not sure exactly what stent it was, but what I thought was happening here was that there was a stent fracture, and that's what led to whatever this material is in this area. So anybody have a stab at this image? What do you guys think? By looking at this,
An unusual geographic area to have a stent fracture, I think.
It's weird, right? Because there's not a big angulation though.
Exactly. And you checked it and looked fine before. I mean, one idea would be, could it be that there's a compression? I mean, from the actual structure of the artery, proximal right corner artery. It's not at the ostium, but it's also in an area where you put your stent and everything looks fine, and then it starts compressing a little bit, and that gives a pull because it looks like it's almost clean cut between the proximal part of the stent and the compressed part.
Yeah, I agree with that. So anyway, so this is what we thought, and obviously, in this type of situation, I thought that the best option here obviously would have to restent this. So we did. That's what we did. Whether it was a geographic miss, under expansion, calcification, maybe inadequate platelet inhibition, but this is another 4 millimeter Zions, which is a bigger stent than which was implanted last time. And this is a second OCT run after the second stent. And now this is your final OCT run. I think that for some reason this OCT run's not playing, but it's nice longitudinal image. You can see where the geographic miss or fracture or whatever it may be, is now fully covered. The red portions that you see, this is the Abbott's proprietary software for OCT, that suggests, some under expanded struts, which were all heavily ballooned. The patient was then ultimately discharged a couple of days later. He still remains asymptomatic, luckily, but I think that it's a great. What the point here today is that there's lots to think about in some of these cases where imaging can be very, very helpful. Understanding what to do. Goran, what you have done, anything differently?
No, I mean, I agree. I mean, you have to put a stent in there. The question is, why did it happen? And if you have great OCT images to start with, and then one other option, which I can use sometimes when I have issues like this with the compression is to use and renal stents have much bigger stiffness, and I don't think this is an area where there is any angulation that would cause issues. But these renal stents are quite useful, especially in the osteo right coronary artery, and you get a much better radial force from them. The question is then the bare metal stent. So I would probably do a drug-eluting balloon. First off, of course, non-compliant balloons and see that they expand well. Then do a drug-eluting balloon, and then implant a renal stent. The smallest is 4.5, but you can implant them at very low atmospheres, and then you can go back in with your well-sized 4.0 balloon, for example. NC.
I cannot agree more. Brian, any other comments?
Yeah, I remain flummoxed. You know, stent fracture doesn't typically appear that way. Stent fracture doesn't typically present in that time frame. Stent fracture is a risk for restenosis for sure, but not early, you know, like you have here. That almost looks to me like some sort of mechanical, the stent shortening or something like that, but I can't say that I've ever seen that.
Yeah, Dr.
Raj,
Rajiv Gupta has joined us from UAE. His thoughts are thrombus, dissection, missed plaque at earlier angiogram. All of those are possible.
Raj, a quick question. You did the IVUS before and you saw a lot of calcium. You
Right.
did tablator for the same. Is there any role of shockwave?
This is, certainly you could consider that. However, becomes very expensive, the procedure. But you saw on the IVUS after ROTA that one portion of the calcium plate was broken. So it wasn't a concentric full calcium that was not affected by ablation. So, it should, with all the scientific studies that we have seen with rotational atherectomy, if you do have a fracture in the calcified plate, the vessels should expand. And I think it did expand it. So it's, it certainly is a very interesting problem that, whether this was a small, longitudinal shortening of the stent and the ostium, which led to, pulling apart a portion of the stent in the proximal segment, or some thrombus there, and the patient's surgeon and was very compliant with the DAPT. And then we actually ended up doing a genetic test on this patient as well later on to see if he was resistant to Plavix, and he was not. So that's how we came up with this idea that this probably was either a fracture or some form of a mechanical complication of foreshortening of the stent, because of the manipulation of the guide in a previous procedure or something like that.
Yeah, I think I have to assume that it was a mechanical failure either at the stent level, ballooning, and it was probably immediate. And the fact that he was on anticoagulation didn't develop symptoms till it had some thrombus there. But initial failure looks like mechanical failure of the stent or a stent fracture.
I also think the same. Well, anyway, so let's move forward. And now it's always a privilege and an honor to have Dr. Nilesh Balar, vascular surgeon, who is chairman of Department of Surgery at St. Michael's Medical Center in Newark, New Jersey, and associate professor of surgery at New York Medical College, who is now going to share with us a vascular procedure. And it's going to generate a lot of good discussion here.
Okay, let me see if I can share the screen here. Let me see. Where am I? Screen share. Okay, you guys can't see my screen, can you?
Not quite yet.
I have not seen your screen just yet.
Okay, I've been,
So at the bottom, there's a green
yeah,
button that says
screen
share
share.
screen. Click on that.
Yeah, I did, and mine is,
It should show your whole desktop to you, and then you can just pick your PowerPoint.
somehow- music, desktop. Okay. Why is it not able to see my?
Um,
Because I'm able to go into advanced sharing options, multiple.
In the toolbar at the bottom, do you have a
Yeah.
toolbar at the bottom next to
Yeah,
chat?
yeah, I saw that. I'm sharing
Yeah.
the screen, but somehow I can share all participants.
it says one participant can share at a time. Maybe.
Yeah, I'm on one participant.
Right, but is anybody else on? No. Goran, you're off, right?
I'm just trying to see.
double click on it.
I want to make sure that I'm not sharing anymore, and that may be the problem. Let me just see here.
It should be multiple participants also. I cannot
I'm gonna
have
try
it
to
on my computer,
I'm
but
gonna try to close my PowerPoint and see if that makes it.
open system preferences, security and privacy, share, open. It might be related to me. This is my computer, desktop, advanced, wide.
Okay, try now.
Okay.
Because I changed a setting in there to see if that helps.
To basics, desktop, it comes with a weird allow Zoom to share your screen. Yes. Open, grant, multiple, one participant.
Yeah, I granted multiple accesses.
Okay. Doesn't let me do that. So if it's okay, I can.
Yeah, I think let me have David.
Or I can send the. I have it on the mail.
Can you, David? Can you let's go ahead and do the journal watch of Dr. Vetrovec.
Yeah,
In the meantime, we'll give a
work on
couple
this.
minutes for Nilesh to sort out.
Sounds good.
Yeah.
Okay. So Dr. Vetrovec is a emeritus professor of medicine at Virginia Commonwealth University. And he is going to do this segment every time we do this called the Journal Watch. It's basically going to summarize some important articles with some discussion, and not any targeted to one journal. It's targeted to whatever is out in interventional. Obviously, we have 2 or 3 recent large meetings, so we have picked some nice trials, which I think would be very pertinent to what we're discussing today. So David, if you are there and if you have the ability to play Dr. Vetrovec's video, go ahead and play that.
Sure, I'm here. Can you see this?
I absolutely can.
Okay, here we go.
Good morning. This is Dr. George Venturebeck, Professor Emeritus, Virginia Commonwealth University, providing summaries of recent trials for discussion at the C3 program on this Saturday. I'm sorry I can't be in attendance, but hopefully this background information will provide the opportunity for a rich discussion. The first trial I want to talk about is the optical coherence tomography guided or intravascular ultrasound guided PCI, the so-called Octavus randomized clinical trial. The key points here are that considerable data has shown that using intravascular imaging with PCI provides better results compared to just angiographic guided intervention. Despite that, there's been slow uptake of using image-guided therapy, and there is the question as to which technique, OCT or IVUS, is the better one to use for imaging, recognizing that the modalities have different characteristics of what they evaluate. So this trial was done in South Korea by Dr. Yoon Hang and his co-investigators. And it was a trial in which patients were randomized to either imaging modality that underwent successful PCI. It was done in 9 sites in Korea. The primary endpoint was target vessel failure, which was defined as a composite of death from cardiac causes, target vessel related myocardial infarction, or ischemia-driven target vessel revascularization in 1 year, statistically comparing OCT for a non-inferior outcome. Secondary endpoints included the individual endpoints within the composite endpoint, as well as looking at the risk of acute kidney injury and procedural safety outcomes. A total of 2,008 patients were randomized, 1,005 to OCT and 1,003 to IVUS. At 1 year, the primary endpoint occurred in 2.5% of the OCT group and 3.1% of the IVUS group, providing a significant P.001 for non-inferiority for the OCT group. CIN, contrast-induced nephropathy, was not different between groups, with 1.4% versus 1.5% for the 2 therapies. The procedure complications were lower for OCT, 2.2% versus 3.7% for IVUS, but were not significantly different for image-associated complications. So in conclusion, the OCT-guided PCI was non-inferior to IVUS in a diverse group of patients and lesions. Further studies will be needed to identify specific subgroups in which one technique may be preferable over another. Thank you. This is a trial published in the New England Journal of Medicine entitled "The Placebo-Controlled Trial of Percutaneous Coronary Intervention for Stable Angina." This is the so-called Orbita 2 trial. And the key points in this trial are that PCI reduces angina. And the significance of this is the original Orbita 1 or Orbita trial used a control group of patients on medicines for angina, and then compared that to patients on medicine with additional PCI, and failed to show that PCI had a significant improvement. This particular trial was done to see whether PCI compared to patients not on medical treatment had significant overall benefits. And in this trial, which was presented at the American Heart Meeting this past week by Dr. Raj Kumar, senior investigator in this is Dr. R.K. Alimi, the Organ of Two investigators. This was performed in the UK, and what they essentially did was take a group of patients who agreed to have who had angina on medical treatment, were agreed to randomization and withdrawal of medications, followed with a online cell phone type assessment of angina frequency, and then were randomized to either PCI versus continuing on essentially no medical therapy, also looking at whether they needed on the day of evaluation additional angina treatment and also the frequency of angina. It was a moderately severe group in terms of symptoms, and the patients had exercise stress tests to see what happened in terms of exercise time, which was significantly improved following PCI in the PCI group compared to the medical group. And likewise, the symptoms were significantly less for the PCI group following treatment. So the numbers, and these patients had evidence of flow was measured in the coronary artery with a flow reserve of 0.63 on average, with a range of 0.49 to 0.75. And the mean angina frequency was 2.9 with a symptom score in the PCI group compared to 1.41 in the medical group. Overall, the patients did well with minimal side effects. So in conclusion, the patients had stable angina, off medicines. PCI showed a significant improvement in exercise performance as well as symptoms. It was a modest ischemia group. Most patients had single vessel intervention, so it was met with great cheering at the meeting when it was presented, because interventionists had felt attacked in that they believed that PCI did in fact reduce angina, and this study confirms it. The next study that I'd like to discuss is extracorporeal life support and infarct-related cardiogenic shock study that was presented by Holger Thiele and is a multi-center study looking at the impact of using ECLS in patients with acute myocardial infarction and associated cardiogenic shock. The take-home message from the study is that the benefits of ECLS were not seen at 3-month follow-up in terms of all-cause death, and there tended to be more bleeding for the ECLS group compared to placebo. That is, no treatment or medical treatment of the patients, no device treatment. Now, the background of this is that cardiogenic shock with acute myocardial infarction has a variable outcome, but in general, the outcomes have been described as about 50% mortality. This trial utilized a 3-month endpoint and randomized 417 patients with 30-day follow-up in using ECLS in
Where'd that go?
47 with mortality of 47.8%,
Think to my phone, man.
49.0%.
Do something to my phone.
Control group treated medicines only. There was obviously no significant difference in outcome in those groups. There's been multiple comments and criticisms. Was 30 days the right date? Was there any difference in terms of patients who had different levels of associated severity of shock? The trial was meant to enroll significantly ill patients so that 50% of the patients were class D or E based on SCNI classification. It also included patients who had cardiac arrest. Dr. Thiele said that those patients were included because they weren't in the real world. So at this point, the outcome is that ECLS did not make a difference in terms of acute MI cardiogenic shock. Now, changing themes just a bit, this is a study looking at the outcome long-term of percutaneous surgical valve replacement versus surgical valve replacement. And this is the 5-year outcomes of transcatheter or surgical aortic valve replacement that was presented by Dr. Carr and colleagues in the so-called Partner 2 investigators. This was a trial in which 2,032 intermediate risk patients with severe symptomatic aortic stenosis from 57 centers were randomized to receive either a TAVR or a surgical valve replacement. The patients were followed clinically and by echocardiography over 5 years. The primary endpoint was death from any cause or disabling stroke. At 5 years, there was no significant difference in outcome for death or stroke comparing the two groups. The incidence was 47.9% and 43.4% respectively, comparing the TAVR versus the surgical groups. There was no difference related to access to site, but the incidence of death or disabling stroke was higher for the TAVR patients compared to the surgery patients in the transthoracic access group. Repeat hospitalizations were more frequent after TAVR than after surgery, but aortic valve reinterventions were more frequent in the TAVR group. The etiology was different in that the TAVR patients tended to have stenosis, whereas the surgical patients tended to be reoperated on more commonly for endocarditis. In the conclusions, in intermediate risk patients, there was no significant difference in the incidence of death or disabling stroke at 5 years. The criticisms or limitations of the study are that 5 years is still only a moderate time of follow-up in terms of valve integrity. Secondly, the SAPIEN KT valve is no longer a used valve, and so how this relates to other valves is unknown. And importantly, these patients on average were 81 years of age, so that this study does not apply to younger, significantly younger aged patients with aortic valve disease, and particularly in patients without with minimal symptoms. Thank you very much.
Okay, so let me summarize two important studies. I wanted to stop the video intermittently, but because I don't have the control of the video, so I'm sorry I was not able to do that. But Octavius trial came at the heel of another study called ILUMIN 3, and ILUMIN 3 was the OCT holy grail study, which was going to show, you know, whether OCT would have been a largely successful, but it really did not show a significant benefit in comparison to an angiographic PCI. So I think that there has been, you know, some discussion about whether is OCT as good as IVUS, because there has been a plethora of studies demonstrating a benefit of the IVUS. And my real, take on this is that, you know, it's really up to the operator and what they are comfortable and what they know. So if they know how to interpret the IVUS really well, you know, and they certainly can use that. In my center, in my personal experience, I love OCT. I do a lot more OCT than IVUS. I am very, very good at interpreting OCT on the fly. It doesn't take me that much time. I like the high resolution images, especially with evaluating calcium. So I think it really makes a big difference. But it was reassuring to see that the Octavius trial showed that the OCT was non-inferior to intravascular ultrasound. And I do believe that over time, imaging will become more common. The other important study that Dr. Vetrovec just talked about today is the Orbita 2. And I think that that's a very, very important trial, because Orbita 2 was one of the first studies of its kind, which looked at PCI in patients with stable angina in addition to medical therapy, which showed a benefit, which is really fantastic. That symptom benefit was seen with PCI. I'm going to table the discussion for ECLS shock and a partner 3, which I do not believe are such a new findings, you know. And we'll go ahead and now invite Dr. Balar back. It seems like that he's able to share his screen and is ready to present his case. So once again, I'll stop here and we'll take comments and discussion after Dr. Balar's
if they're washed once in the washing machine.
Case. Nilesh, can you share your screen now?
Yeah, let me do that.
Because I saw you just a second ago.
Yeah, no,
there
I
you
was
are.
trying.
Oh, I can see it now.
Good.
Yeah.
Okay, sorry about the confusion.
That's okay, no problem.
But so this is let me see. Yeah, now it's a full screen.
Yep.
So it's an interesting case. I will just present initial part. So to make it very brief and short, it was a patient, 81-year-old male with a ruptured aneurysm that was diagnosed in the emergency room. He went to his primary care physician, who felt a big mass in the belly. And the 2 symptoms that he had was severe abdominal and back pain and discoloration of his both lower limbs. That prompted him to be sent to emergency room, where they got a CT scan. And to cut the long story short, he was hemodynamically reasonably stable, looked like he was going into CHF with bluish discoloration of the leg, both lower extremity, and severe back pain. So CT scan showed that he had a large aneurysm, which was 7.3 by 9.8 infrarenal with aortocaval fistula in the distal portion of the IVC and iliac vein. So since he was hemodynamically stable, we got him into the operating room under local anesthesia. The plan was to access. He had a decent neck, and our plan initially was to just go ahead and put a stent and see how he does without intubating him or making him hemodynamically more unstable by inducing anesthesia. So under local anesthesia, as you can see on the image, we went ahead and on the image, you can see there is a filling of the sac, but also the vein gets filled up with the contrast. And you can see our primary stent placed on one side. We are cannulating the other side of the gate. And as soon as we did that, you can see we completed the repair. But here you see on the top portion, there is type 1 endoleak. And initially on the completion angiogram, we saw a lot of contrast coming through. So one problem was type 1 endoleak. To fix that, we decided we will extend the neck. And as you can see here, we came from radial artery, access the right renal artery. You can see our wire and catheter and a stent ready to be deployed while we put the extension cuff on the other side. So we extended the cuff and we put the chimney on the right renal. And after we fixed that, we were able to fix the leak from the top portion, and that was good. So this was basically the repair that was done: a main body, left extension graft, and the neck extension with the right chimney. And upon completion here, you can see there is still the sac filling up.
Yeah. So Nilesh, if I may stop you and ask a couple questions.
Yes.
Could the proximal type 1 endoleak could have been predicted from the beginning of the procedure, given that the neck is so angulated that that this patient may need the chimney from the get-go, or did you or it was not expected?
No, there was a potential, but remember, this is a ruptured aneurysm in the middle of night.
I see.
You are hoping it's not an elective repair where I had all the options to plan it out. It's done under local anesthesia at around 12 or 1 o'clock at night.
Wow.
So we did anticipate some of those issues. We did not have good imaging, didn't have that many options. The only thing we were considering whether we need to open him or do endovascular. If we do endovascular, do we want to do it under local or general anesthesia?
So now the dye that's filling the sac, do you think it's more going into the venous system or it's actually in the aneurysm sac?
That was the debate we had, because now it's 3 o'clock or 2:30 in the middle of night. We are seeing this. He's hemodynamically very stable at this point. He has no other issues. And every time we inject, we see this contrast lighting up later in the time frame. If we let it run through for a few seconds, you can start seeing the sac filling over and over. So the bigger question at 3 o'clock in the night is, what do I do next? Because we extended, we fixed the neck proximally. So it's definitely not type 1 leak. We don't know if it's type 2 leak or is it something different? Should we classify it type 2? And should I do anything more at this point or let it go? And I'm sure some of people here would be doing some of the aneurysm work. What would be your suggestion at this point? Should I pursue to fix this problem at this point or fight the battle at some other date?
What do you think, Nilesh, that to give guy some protamine, and reverse his anticoagulation and stop the procedure, and give him like 24 hours and do another CT?
Yeah, we didn't use heparin on this case.
Okay.
Did the repair, so there was no reversal. 24 hours you can give it, I agree. But the interesting concept about this one was we did not know how it would respond. If it's type 2 leak, I'm not too worried. That will close. And that's what we did. We ballooned all the areas and then we still saw the leak. So it could be either type 2, but doesn't look like type 2 because you don't see lumbars lighting up. You just see the dye filling into the sac. Sometimes it's going to be, you could have type 3 leak, which is the leak between the fabrics or the graft or a tear in the fabric. That you would be able to locate, which on this case clearly is not the case. Diffusion through the graft would be a concern initially, and that could be treated with reversal and weighting. That also did not look very good. I mean, didn't look very promising that that was the case. So sure enough, we waited and we took him off the table because he was hemodynamically stable. We thought we would repeat a CT scan and do these things later on. So there are not that many reports. Aortocaval fistula is a very interesting phenomenon. And I think personally, the leak that you see is not one of those leaks that is classified in any of the literature because there is only up to 5 types of endoleak. And this does not fall in any of those categories. This probably is the leak either from the lumbar going into IVC and creating what we call EV fistula. And that is a different kind of endoleak. And in his case, 72 hours later, when we imaged him again, it stopped leaking. But there is another patient who continued to leak and got into CHF over at least 6 months. And there the treatment would be to put either IVC covered stent to seal the hole on the other side. So the biggest debate is it should be recognized and probably you can wait and watch. And if it persists and patient gets into CHF, you want to follow them a little more closely than the typical type 2 endoleak. So he did fine so far, and he hasn't developed endoleak, but that was the interesting presentation.
So there was a comment from Dr. Popala about that could this be due to low sec pressure due to fistula and porosity of the graft?
Its possibility is there because the porosity of the graft initially can be expected. And being a ruptured aneurysm, initially, if I had fully anticoagulated the patient, maybe I would buy it. But we were there almost 2 hours and porosity of the graft could be there. I can't disagree with that. But there, as I mentioned, there is a case where you would have lumbar leaks going into low pressure system, IVC, that can be a persistent AV fistula leading to CHF on these patients because that's a low pressured system and then the fistula maintains its flow. So you would have to follow them, unlike the typical type 2 endoleaks where observation is only treatment unless the sac enlarges or something else happens, they close in 6 to 9 months. But in this case, since it's an AV fistula with an outflow tract, you want to keep a closer eye on it. So it's a little bit different. I think as far as classification goes, it's not very typical class. They may have to extend the class to class 6 endoleak, which would be the aortocaval fistula, because that's a venous outflow. And
Now,
covered
obviously,
stenting.
this patient was a good surgical candidate. Do you believe that the surgery would have been a preferred option rather than doing an emergent endovascular AAA repair?
No, in this case, I would stay away from surgery because the blood loss, when you have such a large aortocaval fistula, on open surgery, you would be looking at controlling both, not only the artery, but the venous control. And if you try to get the venous control, you are going to lose a whole lot of blood. And this one is an 81-year-old guy who has had this problem. So I don't think open, I've only done one, and that was a nightmare because it bleeds. Even though you control the arterial side, the venous side bleeding is very hard to control. You have to put balloons into the hole from the arterial side to control it and then close it. Nowadays, with endovascular option, you're better off just putting a covered stent on the venous side if you need to.
Okay.
That's not
So-
so easy, though. I mean, that depending on where that is, that might be tricky business. Identifying the site of the leak and putting a covered stent and not obstructing venous outflow
Exactly.
to
Yeah.
that's. So I would argue that at 3 o'clock in the morning, waiting and making sure you have to do that would be a wise choice.
Yeah, at 3 o'clock, it didn't look like a wise choice. Plus, he was hemodynamically stable. So I said, let's leave it alone and we'll see.
Yeah, I think that's absolutely the correct clinical call. I would have done the same thing, that you stop and see how things go. Yeah. Brian, any other comments regarding Nilesh's case or the trials which were presented before we close out today's program?
No, I think it was a pretty good job on George's part to sort of pick the trials. They were all things that I was sort of on the edge of my seat watching. I think to your point about imaging, the takeaway point that I have had and have continued to have about which choice of imaging, the answer to that question is yes, which is just use imaging. If you happen to favor and are very good at using OCT and you favor doing that for primarily, great. If you happen to do IVUS and you're more familiar with that and you're more likely to pick it up, go with that. But the biggest answer is pick up something, take a good look from the inside of the blood vessel. And I think that continues to be the body of literature that we get on this topic.
No, I 100% agree. I also think that it was encouraging to see the symptom relief with PCI in stable angina in Orbit 2, which I think is also a big step forward because we have had a lot of negative studies with this. So I think that's very good that we finally are finding the true subset of patients which are really benefiting from interventional treatment. So I think we're exactly at 11 o'clock, and the time is done. Thank you very much, everyone, to join on Facebook Live from many different parts of the world, and as well as on Zoom. You all have a great rest of the weekend. We look forward to seeing you on mid-December for the next edition of C3 Live. We have some fantastic speakers that day and another set of great discussion. So we look forward to seeing you again. So thank you very much.
Thank you.
Thanks, everybody.
Yep.